Here's an ad for Valium. Well, if I had a molecule that would turn this lady into this lady, it'd be worth gold, wouldn't it? And so there's your Librium molecule. I'm sorry, that's the Valium molecule. This is where this molecule sits. This is the GABA receptor sitting in the nerve cell, and benzodiazepines sit here. This is a very complicated molecule. It's got lots of subunits and lots of varieties, and it's found scattered throughout the entire nervous system. This is the most important inhibitory receptor in our nervous system. It wasn't invented for Valium, though. It was invented for GABA, or gamma-aminobutyric acid, this nice little molecule. Basically, it's amino acid, like which goes into our proteins, although the brain uses a lot of variant amino acids as neurotransmitters. Okay? So we're going to, just for fun, show how this works for people who are curious. This is meant to be a nerve cell. There's the cell membrane. Here's the inside, and here's the outside. And there is an electrical charge across this membrane. Our proteins have a negative charge, making things a little more negative here. And the cell works very hard all day long, pumping potassium in and pumping sodium out. And that makes the potassium one out and the sodium one in. And there's a constant electrical charge on this cell. When your cell fires, what happens is this negative electrical charge gets reduced a little bit or made a little more positive, and at some point sodium channels will open up, and the sodium comes rushing in here, making the whole cell more positive. And it'll reach a peak, and the peak makes those sodium channels close again. And then the electrical signal, as the potassium's pumped out, will slowly return to its negative. This is the famous action potential. This is a nerve cell firing. And then you can see it there, all looking exciting there. Okay? Now, why does the cell get a little more positive? It gets a little more positive because of other neurotransmitters. Glutamate's the most common one. Glutamate may come up in our conversation later. Glutamate's released by another cell at the end of its axon by its action potential. And this little bit of glutamate here, there can be other things that do this too, cause some channels to open here, and cause the charge to get a little more positive, just a little more positive. And if this happens often enough or gets high enough, it'll cross a threshold. And when it crosses this threshold, the sodium channels will open, and it'll get this huge electrical signal that happens. Okay? Now, the GABA receptor here, when it's open, lets chloride through. Here's this chloride over here, and when chloride comes through, the cell becomes more negative. Okay? Now, I don't have a picture of that, but here you see the neurotransmitters trying to make the cell more positive to get it to fire. Picture the chloride going the other way, making it a little bit more negative, making it harder to fire. So when you have GABA released in your brain, chloride channels open, the cell becomes more negative, you get less action potentials, which basically means you get less brain activity, less nerve cell firing. You get sleepy, you get tired, you get calm, you get relaxed, you might stop breathing. Okay? Now, this is where GABA comes to this receptor. Here's its neurotransmitter, and here's the benzodiazepines. But you can see a lot of things are happening at this receptor. This is a big molecule, a complicated molecule, and important. It's bind here. We see that in our patients taking soma most commonly. But you might see Furacet or Furanol has a barbiturate in it. Some neurosteroids. This is not like you put on your skin, but it turns out that steroid molecules end up being very complicated in the regulation of the brain. We're still trying to figure that out. And here's a lot of cool stuff you never heard of before. I don't even know what that is. Okay? Alcohol binds here, and alcohol, more than any other thing, is probably primarily a drug that increases GABA activity. Okay, so let me just say, if we take benzodiazepines or barbiturates or somehow get extra GABA, we feel calm, we feel relaxed, we feel happy. Like that Librium ad said, we're more accessible and communicative. And this would be great, but there's a problem, and the problem is adaptation. So the brain is made to achieve a homeostasis. There's a lot of regulatory systems in the brain. We understand very, very few of them. But the brain can deal with gradual change very well and return to its equilibrium. This is why you can't stay drunk all the time. If you always have an alcohol level of 200, after a while you seem normal with an alcohol level of 200, right? That's called tolerance, right? The same thing will happen with benzodiazepines. The first time you take it, there'll be a big effect. Your chloride channels will open, all your nerves will stop doing things, and you'll feel calmer. But after a while, so there's a regulatory change, such as those GABA receptors, those chloride channels become less responsive in somehow, and you become tolerant. Okay? But you also have physical dependence. Now your brain's gotten used to this down-regulated state. And if you take away the thing that's making GABA work extra, the benzodiazepine, the Valium, suddenly you have a lack of GABA inhibition. And a lack of inhibition is sort of like extra stimulation. and suddenly you've got too much brain activity. Brain cells are firing to excess, and that's physical withdrawal. So when you get withdrawal from benzodiazepines, very similar to alcohol, you have a lack of GABA inhibition, an excess of neural activity in basically all the parts of the brain. Right? So you get too much brain activity. And I'm going to show you a couple ways these symptoms are cut out, but you can look at this list. Now these lists in its different way it's divided are definitely not evidence-based. Some people who've been around a lot of folks in withdrawal made these lists. But here's some vital sign things we see. Rapid heartbeat, high blood pressure. They say fever, but much more often than fever we get feverishness. People feel feverish. Very rarely do they break a fever. We get all these GI symptoms, especially poor appetite, and all these things lumped under central nervous system. Trouble sleeping and irritability, nightmares, sensory disturbances. You might consider that kind of like having hallucinations. A lot of people are remarkably sensitive to sound. Sounds just drive them crazy. Taste. They may complain of a metallic taste in their mouth or their food tasting bad. Okay? Tremors, anxiety, agitation, and hallucinations. What else we got? And then severe things like having a seizure, delirium, or dying, which would be pretty severe. Okay? There's lots of other things you could put on this list. We saw a guy who was hiccuping all the time. But it kind of makes sense. Too much nerve activity, right? Okay. Somebody else diced them this way into frequent symptoms. I think a little bit of opiate withdrawal symptoms get lumped in here. Less frequent symptoms. I like blurred vision. This is hearing too much, hyperacusis. We have a patient last night who complained of that on the unit. Okay? Hyperreflexia, which they call less frequent. I see this very commonly if you test for it. And then less common things or uncommon things. Tinnitus is ringing ears. Amongst the patients we admit to the hospital for benzo withdrawal, these symptoms are quite common, and most people will, in fact, have these symptoms. Okay, so when do these things occur? Now, alcohol withdrawal is pretty clearly characterized. Alcohol has a pretty fast metabolism. The level drops 20 to 30 every hour in pretty much everybody. In a few hours, alcohol's gone. But benzodiazepines have a longer, slower metabolism and a much more variable metabolism from one drug to the other and between people. And there's not a lot of research that proves these things. But we're going to see longer and less predictable withdrawals. So this is kind of a scrunched up table, but this is meant to be how quickly it begins, when it reaches its peak. That's going to be very important for our sake. And duration, how long it's going to last. But I would say this duration is a very controversial topic because, you know, at what point is it gone? At what point are you no longer having symptoms? When you can sleep at night, when you don't have rebound anxiety? It's hard to draw that line. People who study cognitive abnormalities will see things as long as 6 months out, some difficulty. So there are definitely persistent symptoms in some people. But look at this peak, 1 to 5 days. That's a pretty big range. Peak for alcohol withdrawal is 2 to 3 days. And here for longer-acting benzodiazepines, Valium and Librium, you can put clonazepam or Klonopin in this list, 1 to 9 days. Okay? So the time to when these symptoms peak is going to be a while. So if you get used to them and they're okay and they're hard to stop, why stop? Why not just keep taking them? And patients will ask me this all the time. Well, what's interesting, even though there is adaptation and people do seem more normal on them, they're still not normal. This isn't quite a distinction to methadone. People who are methadone maintained, in most ways you study them other than constipation, they seem to be normal. Patients who are benzodiazepine maintained are not normal. They still have cognitive impairments. And these can be fairly significant, even in people who take relatively low doses by prescription. So you can definitely see a memory problem. The memory problem is a difficulty getting short-term memory into long-term memory. And people usually complain of forgetfulness. You see problems with judgment. This is a very common thing. And I recently read a study, though I couldn't find it last night, showing patients on benzodiazepines are more likely to be victimized in a crime because they're sort of less careful. And you see risk-taking. We had a young man the other day, an 18-year-old, who loved his benzodiazepines because they made him more willing to do things he was afraid to do. How many parents would like to hear that from their kids? And also more willing to talk to girls. Okay? So these cognitive impairments are very significant. And you see a lot of patients who have persistent things going wrong in their life. There's a classic story. I was asked to evaluate a patient who'd been on benzodiazepines for 18 months. She was prescribed them because of a date rape and a really traumatic episode. But if you parse the medical record, you could see her benzodiazepines were in fact started 6 weeks prior to that episode. Okay? Might not have happened otherwise. Okay. Now, we admit people for addiction problems primarily, and the real question is how does the prescribed benzodiazepine affect their sobriety? So if you have someone trying to quit alcohol, which is primarily a GABA-ish drug, who's prescribed clonazepam, which is primarily a GABA-ish drug, it seems that this would likely be a problem. In fact, there's no compelling evidence base one way or the other that I could find, compelling research that I could find. Okay? When benzodiazepines first came out, people certainly were encouraged to think you should prescribe them for alcoholics. It's one of the reasons people in AA don't trust doctors to this day. Right? The practical experience has been that this doesn't work out very well. For people who are on methadone at the methadone clinic, the sense is that patients on prescribed benzodiazepines do terrible and don't do well and don't stay sober, and they have relapses. We see many people on prescribed opiates who seemed more or less okay until they were additionally prescribed relatively low doses of Xanax or Ativan or Klonopin, who suddenly escalate their opiate use significantly, or seem to be suddenly way more impaired than they were. So it seems that for people who are trying to deal with an opiate problem, whether it's medical or addictive, or for trying to get sober from alcohol, that these things really get in the way. And then this is the most important thing to me. These drugs are prescribed for anxiety and insomnia. Okay? And it's certainly true that when people start taking them, they're less anxious and they sleep better. But there is this adaptation. That effect is not preserved. And you could ask the question, if you've been taking them for 2 weeks, or 6 weeks, or 12 weeks, are they still helping? This turns out to be a very difficult thing to prove, because the subjective experience when you take them is you feel better when you take it. The way in which it can make you more anxious or more nervous occurs when the drug is wearing off. And it's very hard to compare your anxiety today to your anxiety in the past. I saw some studies from the really 70s and 80s that definitely seem to suggest that the benzos had a long-term positive effect, and they became very popular in that era. The quality of those studies was fairly poor in the sense that the only way they measured the efficacy was just to ask the patient. There wasn't a sort of an external functional or family assessment. But it's very hard to say that they're not effective. But what we have seen is that when people come off their benzodiazepines, and there are a number of studies looking at this, people who taper down and come off very predictably are less anxious and sleep better when they've stopped their benzodiazepines than they were when they were still taking them. Okay? Now, there is some selection bias in this. If I take 100 people and I ask them to taper off, some of them will successfully taper off, depending on the study, 50 to 75%. Others will not succeed in tapering off. In tapering off are sleeping better and doing better than they were before. They were also doing better than the people who said they couldn't taper off. Right? Those are obviously somehow different people. So it's not proof, I would say. But again, we've seen when people come off these medicines, typically the thing that they're taking it for gets better off of it than on it. And that's going to be very important when we talk to patients. Okay, so if we've decided to stop, if we've convinced somebody how to stop, how should we do that? Excuse me a second. It's telling me to come here. Okay. One thing you could do is use the drug the patient's using and just wean them off, right? And that's kind of the standard thing to do. Take the drug the patient's using and wean them down. That's basically what we do with our alcohol patients, except we substitute a similar GABA drug, a GABA agonist, or I'll say GABAergic drug, right? And wean them down. Or you could not give them a GABA drug and use other kinds of medicines to try to help them through it. Or you could do both, a little of each. Okay? Now, if you want to wean, it's going to take a while. There is, we use the CEWA protocol for our alcohol detox patients. There's a fairly good body of research in pretty healthy patients showing this is effective and the best strategy, the most effective strategy with the shortest length of time. With benzodiazepine, we don't have that kind of research, or not very impressively. We have mostly advice from people who work in the field. So here's a piece of advice. Wean them down as an outpatient 10% every week or two. Okay? Now that seems reasonable. It's slow and it's steady, and it probably works very well for lots of people. But if you have benzodiazepine dependence, if you have an addiction to benzodiazepines, this cannot work. Because dependence in this sense, addiction, is a loss of control of how much you're taking. And it happens frequently that the doctors will write out a complicated weaning schedule, and the patient will take all the meds before Thursday and come back on Friday, right? So weaning down as an outpatient is, I think, probably the gold standard, probably the safest thing to do, probably the easiest for the patient, and a good choice for patients who are, in fact, able to do this. But people who are addicted to the benzodiazepines certainly cannot do this, and it's unfair to ask them to do this. Well, you could bring them into the hospital and wean them down. And again, authorities suggest weaning 10% per day. Okay? Now, this is a reasonable idea, and again, it's been done relatively safely without too much trouble by people who work in the field. It will result in a fairly lengthy stay in the hospital, and I'll show you how it'll be more than 10 days. Okay? Now, before weaning down, a lot of people like to switch the drug off to something that lasts a little longer. If you're trying to wean somebody from a drug, you really want to avoid those peaks and valleys. You're trying to aim for a steady level. Yeah?
I was wondering, back there you said on the outpatient you were going to wean them 10% per 1 to 2 weeks?
Yes.
But in patient 10% per day?
Per day.
That's quite a drastic change.
It is quite a change, right? Although people may not want to spend 6 months in the hospital. Okay. So if we're going to substitute for a longer-acting drug, what do we got? The long-acting benzodiazepines, Librium, last a really long time. Its half-life is up to 30 hours, but if you look at all the metabolites, it has this long and variable half-life. It also kicks in kind of slow, and this is often a good thing. Drugs that kick in fast are very reinforcing. They make you want more. Drugs that kick in slow are much, much less so. So that's kind of an appealing option. A lot of authors like Valium or diazepam. This also has a very long half-life. It kicks in a little faster, so patients are more likely to misuse it or to find it compelling, but still it weans off real slow. Valium has a special advantage that it comes in a liquid preparation. So if you're trying to wean really gradually, you can get down to a very low dose. Librium is not too bad. They make a 25 milligram pill that you guys know so well, but they also make a 5 milligram pill. 25 milligrams of Librium is often thought about being 1 milligram of Ativan. So 5 milligrams is only like 0.2 of Ativan. That's not so bad, right? But the Valium does have that special advantage of having a liquid form. But probably the best thing to do, at least in some people's hands, is phenobarbital. Now this is a barbiturate, not a benzodiazepine, but it actually works in the receptor in the same GABA receptor. It has an even longer half-life. The onset of this is really unclear. I think in an IV form it has a very fast onset, and in an oral form it has a very slow onset, but I could not find really compelling data to prove that. The problem with barbiturates is that they're more dangerous in overdose. Benzodiazepines will work at the GABA receptor in the presence of GABA. If there's no GABA, they won't open the receptor. Barbiturates will work even in the absence of the GABA neurotransmitter. So it's easier to overdose and much easier to get respiratory suppression and to die. And in fact, benzodiazepines were the hot new drug in the 60s and 70s because they didn't kill people as much as barbiturates did. So if you know what you're doing and you can monitor patients carefully, this might be the best of all, but we don't use that here. Now, this is weaning by 10%, and I just made this graph with my little spreadsheet, and I wanted to show you the difficulty of weaning. When we wean, we don't go at a straight line, 10% from day 1 to day 10. We go 10% of the current dose each step. So if I start at 100, I'm going to go to 90, and then I'm going to drop 9 to 81, I'm going to drop 8 to whatever it is, but the steps are going to get smaller and smaller. This is very important in weaning. Smaller steps at the end are really critical, but it makes it take a while. So if I'm weaning 10% per week, to get down to a tenth of the original drug, I've got 20 weeks. That's a pretty long time. And people who wean benzodiazepines often say it's nothing wrong with taking a year or two. Perfectly fine. If I'm weaning 10% per day, again, to get to a tenth of the original drug, I'm on 20 days. If I want to get to a quarter of the original drug, I'm on 30 days. That's a pretty long time to be in the hospital. And this is our fundamental problem with weaning, although weaning is probably ideal in several ways. Okay. Well, we could wean by symptoms, right? So when we do our alcohol patients, we know everybody's needs is different. That's going to be true. The amount they're taking beforehand is going to be different. If we change from one drug to the other, it's very hard to predict what they're going to need. It would seem obvious from the alcohol research that instead of doing a fixed schedule, we should wean them by symptoms. But the problem is lack of sort of research. You could use the CEWA protocol, which we all know so well, but it may not really work. It's never been tested in benzo patients. The one thing I notice is the benzo withdrawal patients seem to be a lot less sweaty, and they sort of seem more psychiatric, more anxious. The anxiety seems out of proportion to the tremor, certainly. So whether the CEWA would work in benzo withdrawal patients is not clear, and it's not been proven. They made a CEWA-B, CEWA-B, B for benzo. Just so you know, the CEWA stands for Clinical Institute Withdrawal Assessment. Doesn't really mean anything. So CEWA-B is the one for benzos, and someone made that, and they really intended it for research purposes. If you're trying to evaluate the interaction of drugs to lower withdrawal symptoms, you need some kind of an assessment. But whether this is meaningful clinically is unclear. There's only one study that I could find that used this to dose someone in comparison to a fixed dose regimen, and it did not in fact help. The patients didn't get better any faster, they didn't get any less medicine. basically it was kind of a wash. So maybe if someone designed a better CIWA score, or they designed a better dosing parameter, this would be a super valuable thing, but that has in fact not happened. I don't know if this is legible at all. This is an example of the CIWA-B with 1 to 4 for all these different questions. Are you irritable? Do you feel good? Okay. Here's a graph, but here's I kind of printed this a little bit bigger. So irritable, fatigue, tired, tense, concentration, appetite, numbness, heart racing. And what they do when they develop these things is they ask a lot of questions, 80 questions, and then they do a regression analysis to try to figure out what's independently predictive of the, what's independent, as it were. And these are, I think, valuable for research purposes, but it's not clear if they're valuable for clinical purposes. If we need, stop the tape. If we need to have a number to write down for regulatory purposes, we could certainly use this number. We could also use the CIWA number, but it's unclear if we're going to use this for any, if it's going to modify our clinical protocols in any way. Okay, does that help? So you could probably guess what a lot of these questions are. Should I pause for a second? Okay. Now, you guys are familiar with the idea of giving other kinds of meds. So we could wean them down with benzodiazepines or phenobarb or alcohol, but we often use non-GABA meds to try to help folks. And the research on this is very limited. Some of this is extrapolated from what we know about alcohol. The studies are small and not very well done. Okay? But everybody knows that we like anticonvulsants. Okay? Now, if you look at the Cochrane database of evidence-based practices, they're not too excited about this. And the reason is the quantity and the quality of research is poor. But what we've seen is there are a few studies showing that Tegretol or Depakote can lower the symptoms of benzodiazepine withdrawal. Okay? Now, these studies are, again, with alcohol, there's some pretty good studies showing that. For benzodiazepines, they're very small. One of them was done by Dr. Cullison and Dr. Rees here on our unit before I was here. And I think that's why we use Tegretol, because a study done in your unit is much better than anybody else's study. But in any case, that's how we kind of made this transition. They have been shown to reduce symptoms, okay, to some degree. They have not been proven to prevent seizures. Now, I've said this before. I believe they prevent seizures, because the only time we ever get a seizure is when we forget to do this. That's hardly randomized controlled trials. I wouldn't bet $1,000 on it, but I might bet $100 on it. I'll talk about some specific cases where we didn't do this properly and someone had a seizure to try to convince you, but I believe they prevent seizures. I could find a single reference of someone who had seizures coming off clonazepam or Klonopin when they were treated with one of these drugs. I forget which one. But in our experience, we've never been disappointed, except when we've made a mistake. So here's a case that made a big impression upon me. We admit a lot of patients coming off low doses of benzos, and we start them on Tegretol, and they all seem fine. And I wondered, does this Tegretol even do anything? When I was doing the fellowship, we had a patient who was admitted here and started on Tegretol for benzodiazepines, but the next day it was concluded that she wasn't really taking benzodiazepines. She was mainly here for opiates, and she didn't need that, so the Tegretol was stopped. I was here the day after that, and I saw the lady, and she just looked really weird. She was kind of looking up to the side the whole time, and she was saying things that didn't make a whole lot of sense. It was a little concerning, but because she kept looking to the side, I thought, oh my God, she maybe has bleeding in the brain. Something's touching her brain. So I got a CAT scan. CAT scan was normal, but she came back at the end of that a couple hours later, and she was much worse. Now she's craning her head to the side and her eyes up to the side, and she can't finish a sentence, and she's getting kind of all wiggly and weird. And I got nervous, so I called the neurologist. Right? The neurologist told me to get an MRI scan. Now this is hard because she was kind of twitchy, and I thought it was going to work that well, but if you ask, you have to do it. So I put her through the MRI scan. That took 2 hours, and when she came back, she was a lot worse. Her whole head was craned to the side, and she had what they call word salad, where no two words seem connected to the word before. I got very nervous. I called Dr. Cullison, who's my professor in the fellowship. While I was waiting for the callback, now at 5 o'clock, she had a full seizure, a tonic-clonic seizure. And at that point, it was really obvious that what was going on all day was focal epileptic activity, focal seizures, which is why it had that kind of real tendency to head towards one side. This is a patient who had a seizure because she wasn't on Tegretol. Okay? Here's a second patient. We admitted a patient, yes?
But she had a seizure, but she wasn't on the benzodiazepine?
It turned out she had, in fact, been taking benzodiazepines. It was a mistake. It was a mistake. So she gave kind of a mixed story, and we were able to track it down later. So here's another patient who came to the hospital taking Soma and Valium and Ativan in quantities that seemed too big to be true. She was a woman of large girth, over 300 pounds. See, Fran remembers this. And we put her on Tegretol like we do, 400 milligram loading dose, 200 milligrams TID. And the second day, she had a seizure. I was very surprised by that. So I got a level of the Tegretol, and it was very low. Now, at this point, we were only using Tegretol. So I wasn't sure what to do, so I gave her some extra Tegretol, kind of try to load it up a little bit. And the next day, she had another seizure. So I got her Tegretol level again, and it was still very low. She was a substantially sized person. Right? I wanted to give her phenobarbital, because I knew that that would work, but I called our local backup, and they convinced me that we would make the lady stop breathing if we gave her phenobarbital. And there is a real risk to that. At that point, we started using Depakote, because I knew there was a protocol to adjust Depakote by weight. And when we did the calculations, the amount she needed was very, very high. And when we got the Depakote on board and her level was adequate, she stopped having seizures. Now again, this is still not evidence-based. This is like a guy walks by an accident and develops a superstition. But when we use these drugs here, Depakote or Tegretol, in every patient on benzodiazepines, we have not been disappointed and no one's had a seizure. Okay? Again, we've seen some patients that seem to be a lot calmer on these meds. They have been proven in alcohol withdrawal patients very impressively to reduce symptoms. In benzo withdrawal patients, there's a few small studies, some of which are very poorly done, suggesting they reduce symptoms. We definitely still see people, though, get delirious. They have hallucinations. And when that happens, we'll give antipsychotics. I should mention that Tegretol and Depakote are the ones that have been studied. It might be true that Neurontin works. Lamictal and Topamax have been studied in small open-label trials, which means they give it to 10 people and they all seem fine, and so they figure it's probably okay. It's hard to know what to make of that. But they're definitely options. Antipsychotic medicines have, I could find no significant research demonstrating their usefulness. But they do calm people down, and they're used in delirium in general in hospitalized patients. They specifically stop hallucinations and seizures, hallucinations and nightmares. And in our setting, that seems to be pretty reliably true. And they're pretty sleepy. They help people sleep. So I will usually use one of these drugs adjusted to help the person sleep. Why one versus the other? I don't really have an answer for that for you. Haldol's kind of old and tried and true, but these newer drugs are a lot sleepier, and that's probably good. Haldol is considered a typical antipsychotic. That means old school, which means it can cause tardive dyskinesia, and that's a bad thing, a persistent movement disorder that never goes away. You probably have to take this for months or years before you have a realistic chance of getting tardive dyskinesia. These atypical antipsychotics were invented to lower that risk, and they very significantly lower the risk. The flip side is these drugs make you hungry, it can make you gain weight. We're probably not giving it long enough that that's a concern. So I usually start these medicines and I adjust them to sleep. And most people will sleep, and they wouldn't sleep without them. A lot of folks use trazodone, but I find if they're getting bad nightmares while they're on trazodone, probably that's a reflection of the benzo withdrawal, and these have been much more effective in those patients. Although honestly, this is by practical experience here, and I cannot prove this with a research article at all. Okay? What else we got? You could give antihypertensives. When we talked about alcohol, I demonstrated that propranolol and clonidine have been proven to lower the symptoms of alcohol withdrawal. But one of these guys, I think it was a beta blocker, did not show a benefit in the symptoms of benzodiazepine withdrawal. I can't explain that. Maybe the sweating's not as prominent, and they definitely help the sweating. The tremors don't seem to bother the patients nearly as much as they do the alcohol withdrawal patients, although they do have tremor. We expect these drugs to help primarily with sweating and tremor. They will lower blood pressure, which is maybe a good thing on its own, but they probably don't, or they don't seem to make the patients feel much better. We could give antidepressants. Patients have anxiety disorder, right? It's very tempting to say, stop taking Valium, here's some Prozac, right? In the clinic setting, this is almost always a failure because the patient usually does not want to stop their Valium, and they'll very quickly come back for reasons why they can't take that Prozac and they really need their Valium. Buspar, or buspirone, is a medicine that works like an antidepressant for anxiety. It's a very slow drug, and in general a good medicine. It's been proven to work in people who haven't taken benzodiazepines, and proven to not work in people who've taken benzodiazepines. And the reason is patients who've taken benzodiazepines want benzodiazepines, and they're very underwhelmed with a drug that's going to make them better in 3 weeks. Trazodone probably does help some, though. There's at least one small trial showing it helps in the reason that you'd expect. It helps you sleep. And if you sleep, your anxiety is a lot better. Okay. Antihistamines, a small study, very small, looked at hydroxyzine, Vistaril, and it seemed to make patients feel a bit calmer, and that's certainly been our experience here. You could probably get the same effect from Benadryl that hasn't been studied.
I thought Benadryl was addicting.
That's interesting. How did you hear that?
There's a list of medications from the Washington Health Professionals
That's very
that
interesting.
deal with addicts.
So, Benadryl is not we've talked about how the brain is adaptive in a way that leads to physical dependence and withdrawal. Not every part of the brain, not every receptor system responds in that way. If you think about how SSRIs work, Prozac, antidepressants, the opposite's true. They really don't generate that problem. Antipsychotics don't generate that problem. Tylenol and ibuprofen work in our brain and don't generate that problem. And Benadryl does not generate that problem. In other words, there's no withdrawal from Benadryl. Right?
There is a feeling at home.
Well, there is a feeling, and there's definitely a cognitive impairment, right? But to me, when I'm thinking about the job that we're doing here in detox, we're really substituting drugs. When we're not weaning, we're substituting drugs that have withdrawal for drugs that don't have withdrawal. And people may not like these drugs. They may not like the feeling of Depakote or Seroquel or Vistaril or Trazodone. But the thing is, when they don't need them anymore, they can stop them. And I sometimes talking about the Depakote and the Seroquel, I'll tell people, this is like a cast on your arm. When your arm is broken, you wear a cast, and you hate your cast. It's itchy and uncomfortable, and it feels heavy, and it makes you feel awkward and ungraceful. But at the end of it, when your bone has healed, you can remove your cast, and you're okay. And I think of that in terms of the way these medicines work. We're slowing the brain down. We're kind of tying it in some way that lets the other part of the system, the GABA system, return to normal. In fact, how these drugs work they're different and not well understood. The seizure drugs probably work on the glutamate system, and glutamate is the primary stimulator of brain activity, but there's a lot of uncertainty about that. Anyway, here's two things that are very exciting that I'm hoping we'll try someday. Okay? Dexmedetomidine is an anesthetic agent. It really works in the brain like a superclonidine, if I understand correctly. It doesn't cause any withdrawal. It's not a benzo or an opiate. It works in a completely different system, but it's drowsy enough to actually do surgery on people. And there's a growing research of little babies who were born with birth defects requiring surgery, who were on months of sedation with benzos and opiates to get through those times, and then they can't wean them down, right, because they have withdrawal symptoms, and they've been using this with great effect. Great effect. I asked if we could use it on our unit, and I'm told it's too hypotensive. It drops the blood pressure too much. So we're probably not going to do this unless we have an ICU with us someday. Maybe someday when we have an ICU, we'll do that. Okay. This is really interesting to me. This is flumazenil, otherwise known as Romazicon. This is often described as a benzodiazepine blocker. Right? It blocks benzodiazepine activity. If you have an overdose of Valium, you can take this and you'll wake up, kind of the Narcan, as it were, of benzodiazepines. But which obviously would be bad for withdrawal, make withdrawal worse if that's true. But it's probably a lot more complicated than that. And there's some people in Italy who've done a handful of really very well-designed studies with about 30, 40 patients showing this may really help withdrawal. Why this isn't clear. In some ways, it's like Suboxone. You take it too early, it makes you worse. You take it later, it makes you better. This may, in fact, really be not a blocker, but an agonist-antagonist, like the buprenorphine is. But another theory is that the way the GABA receptor regulates itself, I love to say this, it's so complicated, is that there's an endogenous inverse agonist. I mean, in order to slow down the GABA system, your brain makes a molecule which has the reverse effect on the GABA receptor, right? So instead of opening that chloride channel and making your brain slow down, it closes the chloride channel and makes your brain fire up faster. And if you blocked that inverse agonist, you'd be calmer, you'd be back to normal. Anyway, we don't know exactly what the story is there, but some small studies from these Italian folks look very impressive, and I like to imagine someday it'll be the Suboxone of benzodiazepine withdrawal. If I was fired up with the infrastructure to do research, we'd be testing this, but I don't know how to do that yet. Someday. Okay, so that's kind of the basic story. I'm going to tell you now, with that information, what we do here, and hopefully it will make sense. But let me ask first, are there any questions about any of that stuff? Okay.
Not yet.
Not yet. So that was sort of the background. I'm giving you all the information I have, how we made these decisions. Okay. So this is going to be what we do here for non-pregnant patients.
Let me ask a question. Dr. Smith from the Haight-Ashbury Clinic was talking 15, 20 years ago about not giving benzos to people with a family history of addiction or alcohol. I just got a guy recently on an intake call whose doctor told him to DC his benzos on a 3-day taper. Why is there so little insight in the medical community about benzos? Why is so much of what you've just presented seems to be known by so few or understood by so few?
I think it's two things. One is the quality of the research is very poor. I mean, you can read these things and come to the conclusions you want to a certain extent. There's just not a lot of scientific background for any of these things. In terms of their usefulness, whether they're good to take or bad to take, there is a huge divergent opinion. And there's not enough evidence to say that either side is really wrong. There are psychiatrists that I know who I think are very intelligent, responsible people who I respect, who are very liberal with benzodiazepines and think it's wonderful to be on benzodiazepines indefinitely. Right? There are other people who I equally respect who think it's terrible to use benzodiazepines. Outside of a crisis, you shouldn't use them. I personally wish they didn't sell them outside the hospital, right? But I think there's ultimately not enough evidence to be really compelling and clear. Certainly, the benzodiazepines existed in the sort of pre-evidence era, you know. But I think that in general, the struggle with these meds, which is a familiar struggle with addictive substances and to some extent with the human condition, is that they make you feel better now, and if they make you worse, that's later, right? Right? So this is a real dilemma, how not to feel better now when you're anxious, when you're scared, right? When you haven't slept in 3 days, right? Now seems much more compelling than later. And I think to some extent that applies to all of us. I know myself, every morning in the shower I want to lose weight, but every afternoon a donut sounds really good, right? So.
You know, I'm thinking about Valium, and, you know, my mother-in-law was on it. So, and it seemed like everybody's mother or mother-in-law was on it. That would be a generation that would be in their late 80s, 90s now. But you didn't hear very much about them having a problem with it. But they must have.
They sure did.
Yeah.
So, I mean, to some extent, the prescriptions just continued to go on, so it wasn't really a problem.
Oh, is that?
And if somebody, then this is a tough thing. Stopping benzodiazepines is really hard. Remember, death was on that list, right? So if someone's stable, right, should we just leave them on it? And I think this is a really challenging decision. Now, there is evidence that elderly people on stable prescriptions of benzodiazepines are more likely to break their hip. It's not surprising. More likely to fall down. People are more likely to crash their car. That seems like a bad thing. So in one sense, you could say, of course you have to stop it. On the other hand, stopping it is really perilous. It's hard. It's anxious. But it's also somewhat risky. So I think it's a really tough decision once you've started. In general, people start these things, doctors I mean, start these things not expecting to continue them. And it's very infrequent that a psychiatrist writes a prescription for Xanax for the first time saying, you know, we'll keep you on this till you're an old lady, you know.
And you go to treatment.
What's that?
Then
The doctor
old
perhaps.
lady comes to
Oh yeah, but typically people expect that they'll start it for 2 weeks while the Prozac gets started. Right? Which would maybe be reasonable, but at the end of the 2 weeks, the person feels a little more anxious in some degree, even if the Prozac's working, and very often the doctor will not stop it.
Well, you know, I'm thinking back about that, and because I said to my mother-in-law, well, why are you taking Valium? Because I'm like, whoa, don't take anything. And she goes, oh, I feel a little depressed, and the doctor gave me, just a family doctor.
Yeah.
Not a psychiatrist
Right.
or anything like that, just the family, and they were just giving it to everybody.
Benzodiazepines were the third, Valium I think was the third most common drug, you know, used, and as a class for a while were the most sold drug. So very common, yeah.
I was at the pain clinic for many years, and we had one patient there who came for treatment for benzos and opiates, and we could not get her off of benzos. This is a lady who'd been on benzos for 20 or 30 years. And so I think perhaps there are some people you cannot wean off of benzos for whatever reasons. Also, my other question was, how do you know who is a good candidate for actually prescribing benzos, and how do you predict who, you understand what I'm
Yeah.
saying, from
So-
a dual diagnosis or from a psychological standpoint,
Yeah.
who is going to be able to manage
We're
using that?
on our way. Let me say this from a stopping it perspective. I would never say that somebody cannot, because it's possible to stop them, but it's the risk-benefit, right? And you have to decide how it falls in that fold. In terms of who can take them well, to me, the way I think about this as a physician in the clinic is when you start a drug that can potentially make someone worse in the long run, you ought to have a plan from the first prescription where you're going to be in 1 week and 2 weeks and 6 weeks. But speaking for me personally, I don't prescribe them. Okay, I'm going to move on a little bit and talk about what we do here. Okay, this is at our ARS. This was evolved over time, basically, partly based on that little research trial that Sam Cullison was involved with. But basically, for our non-pregnant patients, we stop them cold turkey. That's what we do, pretty much. We do give them a seizure medicine. And again, when we do that right, nobody ever has a seizure. That's nice. We give them medicine to sleep, usually starting with trazodone, but more often than not ending up with Seroquel. Okay? If they have perceptual abnormalities, hallucinations basically, or nightmares, we'll give them Seroquel adjusted to that. Sometimes Haldol is used. Haldol, aside from its different nature for side effects, Haldol is a faster drug, fast in, fast out. And Seroquel is a slower drug, slow in, slow out. But I try to send them home not with Haldol if we're going to use meds like that.
Why am I so confused right now? Because I've always heard that Xanax is just awful to stop immediately.
Xanax, Valium, Ativan, Klonopin, they're basically going to be the same. They're going to vary by time course. You'll see this again coming up in a little bit. Okay? So now we may need to give a little benzo until we get our anticonvulsants in the system. And these seizure drugs are relatively slow in their onset. Our half-lives are low. Drugs equilibrate at 5 half-lives. Basically, it's going to take us a day or two to have a level in their system that's going to make it likely they don't have a seizure. On the other hand, the onset of the withdrawal is relatively slow. For drugs like Valium and Klonopin, the onset's going to be over a couple days. So usually if I start Depakote at the same time we stop Klonopin, usually they'll just cross. It'll be beautiful. But if they present already in withdrawal, very shaky, very anxious, looking impaired in some fashion, it might behoove us to give them a little bit of benzodiazepine just while these drugs come up in their system.
And what would that choice be?
It depends how urgent it is. So for example, if the patient's taking a Xanax and they don't look too bad, I'd rather use Librium because it's going to kick in slower and they won't ask for more in 6 hours. But if they already look really bad, they're already shaky, and it feels like something bad is impending, I might prefer to give Ativan because it kicks in faster and I can even give it parenterally if I need to. So it kind of is based on circumstance. But for our purposes, where we're going to do a very short stay, a short hospital stay, we're going to give it really just for that initial period till our seizure drugs are in their system. Okay? Good. Okay. So this question here is an important one. Why stop at cold turkey? Why not just taper them down while they're here? That's what we do with our alcohol withdrawal patients. Certainly if we tapered them for 2 days or 3 days or 6 days, their symptoms would be less. Absolutely true. They would feel not as bad and potentially be safer. But here's my ethical dilemma. This is the same picture from before. When is the time to peak? Because what I worry about, and this becomes more of an ethical decision than an evidence decision, is the patient who feels fine the whole time they're here and feels bad when they get home. Right? So if we make if we relieve their symptoms while they're here and send them home and then 3 or 4 days later their symptoms flare, that seems like we've done them a disservice. So for short-acting benzodiazepines, the time to peak is 1 to 5 days, usually 3 days. Okay? For long-acting benzodiazepines, Valium, clonazepam, 1 to 9 days, I'm going to say more likely 5 to 7 days. It's especially tricky if they don't seem to have any symptoms. A lot of our patients don't seem to have any symptoms. Was it just not started yet, or is it just not going to be that bad? It's a little hard to predict, right? So I feel, ethically speaking, it seems wise to discharge them when they're sure they're not going to get any worse. That's kind of I try to make a promise of that to the patient, which to me means I try to get at least 3 days off Ativan, 5 if I can get away with it. I try to get at least 5 days off Librium and Valium. So if I give them some tapering down, if we follow this rule, this goal, we're going to extend their length of stay quite significantly. This is a problem for the patient because they're bored and restless. It's a big problem for the payer who won't allow us to get away with that sometimes. So our sort of short, cold turkey, as it were, withdrawal is really an artifact of the fact that we're doing an inpatient hospital stay. If people were here for 28 days, I'd take longer. Yeah. Right? If they could be here 90 days, I'd take longer still, probably. But when all you have is a hammer, everything's a nail. So we do try to select patients and make sure that this service we're offering them is appropriate for the person who's coming. And we try to dissuade people from coming or decline to treat people for whom this is not appropriate. Okay. Let's talk about our pregnant patients. Now, their experience here is very different. They can stay a lot longer. In fact, they get benefit out of a treatment program. They can stay a month or longer. Okay? And the medication safety considerations are completely different. Because for pregnant people, the kind of medicines you want to give them or feel safe giving them is much restricted. So, what we do with our pregnant people is a more traditional program. We substitute a longer-acting benzodiazepine, and then we taper down. Now, I don't follow a numerical formula, because it seems like that would be too much for a lot of people. But I don't follow an evidence-based symptom score, because I don't have one. So we kind of go by the seat of our pants. We look at the patient and see how they're doing, right? Remembering that you make big steps initially and small steps later, right? And you see how they're doing. We have had, in the time we've been doing this, probably for about 20 or so people, maybe 25, the time I've been here 5 years, we have had one person had a seizure, quite unexpectedly. She was a pregnant woman who had seized before. She was down to getting Librium 5 milligrams, remember that's like 0.2 of Ativan, every other day for the last 3 days of her taper, after about 3 weeks. And we stopped that from that very low dose, and on the third day after that she seized. Probably couldn't have gone a lot slower than that, honestly. But that's the only patient we've had who's seized going this. I look at reflexes and tremors. It gets very caught up with emotional issues and very, very hard to sort out. It certainly impairs their recovery treatment, makes the counselor's jobs a lot harder. But we do this because we're trying to promote the safety as the first priority. Seizures are at risk for pregnant women. If you have seizures, there's a little bit of a hypoxia that occurs sometimes, and that can create some fetal distress. So we hope that our pregnant women won't seize. Okay. These are some questions, before I take your questions, that were emailed to me, which I thought were very relevant, so I stuck them in here. So who's most likely to get DTs? Now DTs is really a term technically only for alcohol, but we can most say who's more likely to hallucinate or get delirious, right? Well, here's the simple rule. That seems illegible. Patients who've had hallucinations are prone to hallucinations. That's not so smart. Patients who've had seizures are prone to seizures. But this is really useful. The best predictor of how bad it's going to go is someone who's had those symptoms in the past. To some extent, that's because the threat, like anybody can have a seizure, and anybody can hallucinate if they're under enough stress. But the threshold each of us have is different. And if you've seized before, you lower your seizure threshold. If you've hallucinated before, you lower your hallucination threshold. So the history will tell you this, but you can pretty much guess that each episode is going to be a little worse than the one before. So that's what I look for. I ask what happened last time, and we anticipate that. Okay? But here's a useful thing to remember. Patients with personality disorders are going to completely fall apart when they're in benzodiazepine withdrawal, predictably. Right? Now, you can't always tell who has a personality disorder. People in benzodiazepine withdrawal don't look very normal in the first place, right? But if they have an underlying personality disorder, it's going to be very rough for the patient and very rough for the caregivers. Yeah.
You know, when you think about previous experience, our street opiate users have been in withdrawal dozens or hundreds of times in their drug-using careers. They don't get them, you know, they can't get the drugs. They have a lot of knowledge of what that's like. Our alcoholics have tried to quit drinking maybe dozens of times in some cases, or at least a few times. But you get a lot of people on benzos who have never stopped. So you have no history you can get.
That's true. That's very true.
So, so it's rare, actually, that you can find out what it's been like for somebody in terms of doing intake screening.
I think that's true, but you can also get a sense, you know, seizures that weren't withdrawal seizures still give you that evidence. So if they've had a history of febrile seizures as a kid, or if they got bonked on the head once and had a seizure, if they had a lot of hallucinations during the periods of other substance uses, that indicates that they're sort of higher risk. But ultimately, it's hard to tell. We admit a lot of people here for some other drug who are also taking 2 or 3 or 4 milligrams of clonazepam or Ativan. And 90% of them, with the regimen I told you about, with the Depakote or Tegretol and the Seroquel for sleep, 90% are asymptomatic completely. And 10% go delirious. And I find often you can't predict. Okay. These are the questions that the patients ask from Steve. How am I going to sleep after I come off my benzos? How am I going to control my anxiety without my benzos? Right? You know, in a way, we already answered this. You may not remember that answer. I guarantee you the patient will not remember that answer, okay? Because evidence shows that when you're off these drugs, patients who successfully quit them will sleep better than they slept when they were taking them. So if they say, what are you going to do for my sleep? I say, I'm going to stop your benzos. But what are you going to do for my sleep? I'm going to help your sleep by stopping your benzos. Okay, hold on a second. Patients don't hear that, though. Patients don't hear that. The exact same thing is true as for their anxiety. If you get them off, they do better. So I do try to tell people we will send them home not getting worse. I try to make that promise. There's been a few exceptions, but I try to follow that promise. And I try to send them home sleeping. And we almost always can meet that if they're willing to tolerate side effects. Yeah.
Okay, now what if somebody has a dual diagnosis? They have an anxiety disorder of some sort.
Yeah.
Plus, and that was the original reason that they were given, panic disorder or whatever.
Right.
And that was the original reason they were given the benzo, and they've been taking it for a while, and you take it away.
Right.
So,
And because I took it away, they will be better. All the patients, not all, almost all the patients we see were started for usually a more or less legitimate psychiatric indication. But the use of benzodiazepines for long-term treatment of post-traumatic stress disorder, very poor. Generalized anxiety disorder, very poor, although there is a lot of debate about that, but generally very poor. They're intended for short-term use because they make things worse in the long term. So we're going to do our patients a favor if they come off of it. But when I say that, I mean eventually they'll feel better, right? Is that 2 weeks or 6 weeks or 12 weeks? It's going to be something like that. So the getting better phase comes later. So this is the reverse of the early dilemma. I'm now asking them to feel worse now in order to feel better later. And that's a lot to ask of people, although it does work.
so it seems to me, what I've seen is that people stop the benzos and then they realize that, you know, they don't have any coping skills, or their coping skills are, they're very limited in how they can cope.
Mhm.
So they leave here, and even though we send them home on Depakote, which is helpful, some of them can't cope.
I think that's really important. People will start benzodiazepines because they're not coping with situations. A very common scenario I used to see in the community health center was women in an abusive relationship will start benzodiazepines to help them handle their abusive relationship. Right? I feel like doctors facilitate a lot of these relationships in that ways. People may have not had coping skills originally, or they may have lost them consequent to using the medications. I think that developing coping skills is real critical. People who slowly wean down usually try to use that as part of the program. Different therapy forms have been shown when tested to help people successfully, voluntarily wean off. There's no proof that one is better than the other, but I think there's a consensus that building coping strategies is really critical. I feel like the time frame that they're here is unfortunately not a good time to do that, because they often feel really terrible while they're here. So, but I think that's a really important part. Honestly, I feel bad we don't have the infrastructure to add that to our hospitalization.
Do you think that we can,
We do it.
can I,
Let's go, we'll go right, go ahead.
do you think we can do a set of orders just for benzo and maybe just small doses of Libremoratavan, very small, like 0.5, and so we can catch up with them?
Again, to me, when we make the choice to give a benzodiazepine, if we're going to keep that promise that the patient won't be worse when they go home, you're going to have a really big impact on their length of stay. For patients who are addicted to benzodiazepines, by definition, they cannot make a wise choice about what they need. So you're balancing off not safety, because our experience has been that we're doing this safely, right? But you're balancing up discomfort versus length of stay, and I think that's a real challenging thing. So I probably would not agree to do that unless we had a real careful evaluation of their length of stay from the perspective of their patient and their insurance, honestly, which has to go into the mix. We could certainly have an order set, though, with the other things, although it's really not significantly different than the alcohol with order set, except for the lack of the Librium Persiwa.
And then the same alcohol set, but why shouldn't get some opiate, PRN from opiate, and clonidine be there too?
Well, again, clonidine has not been shown to be effective for this purpose, so we probably wouldn't use it unless we use it adjusted to blood pressure. Visceral could be used, and that probably is somewhat helpful.
What about clonidine in alcoholic patient we don't use usually?
It hasn't been shown to relieve those symptoms. There's something about opiate withdrawal symptoms that is particularly sensitive to clonidine that may be different.
If you have a Valium addicted patient who's coming in and their onset is, what do you say, 1 to 9 days, I think?
It says 1 to 9 here. I usually say 5 to 7, but that's the
Okay.
idea.
And if they're going to seize on, do you ever tell them to stop Monday and come in Tuesday or Wednesday?
I probably, we do that sometimes with our methadone patients and our OxyContin patients, but opiate withdrawal is an uncomfortable condition but not a dangerous condition. Benzodiazepine withdrawal is, I think, a little more risky, and I would be concerned to give that advice for fear that they would get a little psychotic-y at home. I think very few patients could manage that, honestly,
Yeah.
but I'd be reluctant to give that advice, honestly. So it's certainly easier, just like for our opiate patients, for detox purposes, it's easier if you're on a short-acting drug. You know, for weaning down, we talked about switching to a long-acting drug, right? If you're trying to stop abruptly, in some ways it's better to be on a short-acting drug. But I still probably wouldn't give that advice. I think very few people can manage that. So, Patsy, did you have something you wanted to say?
Oh, not really, but I was
Okay.
just thinking with the coping skills, we had
Yeah.
that stress management that Travis set up. And if we could incorporate some of those teachings at the same time they're detoxing off of the benzos, that might teach them the coping skills that they need.
You know, I would certainly defer to the counselors in this regard, but if there's any ability during that time when they're there, probably at their worst, to help people feel more effective, I think that'd be great. There's a group called Benzowise, people who've come off benzodiazepines. It's kind of an internet support thing, and they do have some booklets and literature about building those resources. I don't know how useful that bibliotherapy, as they call it, would be, but I think it'd be intriguing, honestly.
We also have upstairs different recordings of, different sound.
Oh, that's
tracks and
interesting.
stuff.
That's interesting.
That
Although patients
helps
coming off
them.
benzos can be kind of sensitive to that, so you have to be kind of ask them what they think.
Yeah.
Okay. I think that's, okay, so this is the last thing I want to put in here. This is a very common situation. I think I deal with this every other night. I'm only here to quit drinking or heroin. You can't take my Klonopin away from me, right? Now, again, this is an ethical dilemma, right? Because on the one hand, stopping Klonopin is potentially dangerous, right? And certainly uncomfortable, right? Most of these patients are not abusing their Klonopin in the sense that they're more or less following doctor's orders. Maybe they take 3 on some days, but they really take 2 most days, and they don't really run out early. Right? It's never been a problem. They haven't experienced that loss of control. They might qualify for a diagnosis of DSM dependence if they tried to stop in the past. But for the most part, it doesn't seem like a big disruption to their life. So maybe leave it on. On the other hand, it probably interferes with their efforts to sobriety. We talked about how people do very poorly coming off opiates if they're on benzodiazepines. And if I told you benzodiazepines reduce judgment and encourage risk-taking, risk-taking and staying sober probably don't go together too well in some sense, right? So I like to think that benzos take away your second thoughts, right? And your second thoughts may be your best thoughts in this regard. So it's very likely that this person will have a harder time quitting their OxyContin or their heroin or their alcohol if they remain on their Klonopin. So we have an ethical dilemma. But to some extent, the patient should be in control of this, except their prescribing doctor has to have a say in it as well. So the way I resolve this ethical dilemma, feeling it's probably in their best interests to stop, right? So beneficence makes me want them to stop, but I want to respect their autonomy, right? But I take a step back and call their prescribing doctor. Now, if the patient does not want us to call the doctor and say, my name's Dr. Wallstrom over at the detox center, your patient's on Klonopin, she's here to come off heroin, did you want us to continue the Klonopin, right? If the patient does not want me to make that call, we stop the Klonopin. Okay? And more than half of the patients don't want the doctor to find out the truth of what's going on. And that's to some extent an indication this is not a healthy medical care relationship. Maybe the doctor's cool, maybe the doctor's not that cool, but this is not a healthy relationship. Okay? Almost always when I do make that call, more than 90% of the time, the doctor will say, oh my God, you could stop it? Oh, would you please? Because I've been trying to stop it, I just couldn't do it, right? Now again, this gets into, can you stop it? Because it's going to be bumpy. It's not going to be easy. Does that mean I can't? Well, it depends what your options are, really. So if the doctor, the prescribing doctor, upon becoming aware of the situation, wants to stop it, we stop it, right? That makes sense in a way, because if we send the person home on a benzodiazepine they don't have a prescriber for anymore, that's probably not a very thoughtful, future-oriented strategy, okay? If the prescribing doctor, having heard all this, still wants to take the benzo, I'll do it. Sometimes I think it's a bad idea. Sometimes I think it's maybe, as best as you can tell, probably reasonable. This happens maybe once or twice a year, very, very infrequent. Okay? I'll put this as a caveat. I didn't write it on the slide. If the doctor seems like they don't know what they're doing, I won't do it. Okay? But that's very infrequent, honestly, although I have had some cases like that. There are some particular physicians, often for their own recovery or sobriety problems, who are a little bit too liberal. But that's uncommon. If a thoughtful clinician thinks it's the best thing to do, what's the point of me trying to stop it if they're going to go back on? Okay? But again, it's very rare. When we make these calls, the patients almost always want to stop. Now, sometimes the patient, I should say all the time, this patient arrives at 8:30 at night, right? So it becomes a big drama at 8:30 at night. Until I can speak to this doctor, I won't do it. Now, the withdrawal takes a day or two, so it's probably not a big deal. The counselors on intake know to check for this. Every time I get a call from a doctor about opiates, I always say, hey, are there benzos too? And more than half the time there are, almost universally. When you're taking patients in, it's a good thing to check on. If you're taking patients from the ER, they should know we're not going to continue to prescribe benzos without conferring with their physicians. Some patients, if they thought they were going to get them, will be very upset about that. Ma'am.
How many of these people, because they really like taking their benzos.
Yes.
How many of them go home and start it again, do you think?
I think a lot of the people do. But at the same time, I would say this. If we have encouraged an honest conversation between the patient and their prescribing doctor, we've definitely done both of those people a service. Right? So I think a lot of people do. Again, but if their prescriber is going to not give it anymore, then they're in a different circumstance. And a lot of the folks, when they get here, are out. Not always true, but frequently true. Right? Yeah.
I think it's important to add, too, when we are assessing for a history of benzo use, that we're not just asking that they use benzos, but we're saying them specifically by name, because a lot of the lay public, they don't even know what a benzodiazepine is, even though they've been taking Ativan for years.
So patients with an addictive disorder know about, or who are traveling in that world, know about benzos, right? Patients who get prescriptions never heard that, and they know Ativan, Xanax, Klonopin, Valium. And I always say those 4 names in every patient I admit. I ask them by name. Nowadays, we should also be looking out for Ambien and Sonata and the pretty butterfly Lunesta, right? Because those drugs, although they're advertised as not being benzos, they in fact bind to the exact same site on the GABA receptor. So they're functionally benzos. It's interesting, the ad for Lunesta kind of indicates it's not habit-forming, because they had a small group of patients they studied for 6 weeks, but that's crazy. I mean, Ambien has become habit-forming, and it works the exact same way.
Same thing with Ultron.
The same thing, and again, when these new drugs come out, they often try to make these claims, and they usually turn out not to be true. Yes?
Do you think Ambien is a good long-term option then?
No, I think it's a bad long-term option. Ambien's not significantly different than Ativan. It wears off a little bit faster. You're a little more awake in the morning. But for more than 2 weeks, you get some of the same problems.
I'm just amazed at, I'm thinking about how many doctors are saying, well, you're having a problem with sleeping. Because my daughter has problems sleeping, and the first thing they said to her was, she's smart enough to know not to.
Mm-hmm.
But the very first thing her doctor said is, well, I can write you for Ambien. And she said, oh, no, I don't want that.
So, again, just like benzodiazepines, they have no side effects. They're perfect, and they work right away. It seems to be true. Now, this is definitely not a thoughtful statement or an evidence-based statement, but in general in the brain, things that work fast seem to be the things that get us in trouble, and things that work slow seem to be less like that. I'm not sure what there is about just, God or the nervous system or just plain luck that makes it that way, but I'm always very cautious about a new medicine that seems to work right away.
So let me ask you something. That's a good change in consciousness, okay? When someone takes a drug that's fast acting and they get a change in consciousness and they feel better, okay, whether it's alcohol or an opiate or a benzo, seems like for some people that's a problem, okay? For other people it's not a problem. So I'm wondering if a person who has an addictive tendency would be at higher risk. Seems like, I don't know.
We're really far off the evidence base here, but I'll tell you how I approach this question, and I'm not sure if this is really true, but it's how I approach it with patients. Oh, am I stopping? Pick up here. So this is how I kind of approach that question of why some people get in trouble and some don't. Now, I'm not sure if this is true, and I might just try to be nice, but it seems that the possibility of becoming addicted or dependent to a substance is true for anybody. There are certain substances by their nature are habit-forming or addictive, and this has to do with the way the brain regulates or tries to obtain homeostasis with that medicine. Right? That's caused by the substances. A lot of people seem to be somehow, genetically, if I can use the word, protective. With opiate medications, 80% of people hate taking opiates. From the very first dose, they feel sick. And if you're an intern working in the hospital, you walk around in the post-operative wards trying to get old Mrs. Jones to push her button because she's hurting, but she doesn't want that stuff because it makes her feel terrible. But she's hurting, please take the medicine. Most people feel ill with opiates. If you ask the patients we admit to detox about the first time they had an opiate, that is not what they describe. And I don't believe that's a personality characteristic. I believe that's a genetic variation in terms of the way the brain interprets the substances. With alcohol, there's certain family lines where there's a high tendency towards alcoholism. This has been studied mostly in the father-son line. But what they find in these sons whose fathers are alcoholics, who seem genetically tending in that way, is that they can hold their liquor really good. Most people, if they drink too much, they feel sick the next day. They feel horrible. And it kind of makes you not want to drink the next day. But these folks who seem genetically, I won't say predetermined, but at high risk for alcoholism, they can drink a lot, they're the last person to fall asleep, and they're up to work the next day doing fine. So now
But it catches
benzodiazepines,
up with them.
what?
It catches up with them.
Sooner or later. But I think benzodiazepines, there's very little evidence in that regard. But the way I like to think about it is, and this is what I tell patients, is that normal people living normal lives and with normal situations develop a substance use problem. And it's not the fault of the person per se, it's the fault of their substance. If you're in a bad situation or you're trying to deal with some painful emotions, perhaps that's more likely. But that, in fact, has not been proven to be true. The only studies, which were only done in men, not done in women at all, showed that pre-existing childhood traumas did not predict alcoholism. The only thing that predicted it was family history, actually, so sort of the possibility of developing it. So I tell people it's a normal thing that happens to normal people. It's caused to some extent by the substance. The physical dependence, the loss of control, is caused by the substance. So I think if any of us took enough for a long enough time, we would develop that loss of control. But that many of us will not take it because of circumstances or because of genetic variation that make it seem dysphoric rather than euphoric.
So you said if we all took the same thing, we'd eventually get.
I think that's
the
true.
genetically predisposed people would show addiction earlier, do you think?
I don't know. I don't know the answer to that.
Sounds right.
So,
Can I ask you, regarding documentation of benzo withdrawal symptoms in patients, do you think it's best that we're actually just entering that in a prog note, since we're not able to enter it in like the CWA scale and we don't have the CWA-B? What would you think?
well, if I had to answer this question, I would probably ask an experienced nursing leader like Travis D'Amico. But I think, to me, I like to gather information that's clinically useful. So a narrative is a wonderful opportunity for education. So if I ask the patient their symptoms and try to validate the reality of their symptoms, I can see that you're having nightmares. That's very common in patients with benzodiazepines. I think benzodiazepines withdrawal. I think that's really helpful for people, and I think that narrative format really favors that. I think the numerical format is wonderful for data collection. If we're trying to look at two different regimens and see how we're doing, a numerical system is by far the best. So I think it depends kind of on your goal. For research purposes, no question that numerical systems are critical. And if you're going to adjust therapy to those symptom-triggered numbers, obviously that's really important, but we're not doing that. So I think it's reasonable, honestly, to do a narrative format because it allows an opportunity for patient education. On the other hand, it may not satisfy some of our external agencies that want to measure how we're doing. So there is something to be said for measurement. Our therapy it's more weight-based than symptom-based, though.
Okay. One more thing.
Yeah.
So I just wanted to put it out there that I know there's a lot of evidence to support cognitive behavioral therapeutic techniques in treating people with anxiety and PTSD and such. So I'm just wondering, when we're discharging patients, is there a push from physicians, and I'll check more with the counselors, in order to get them to follow up with outpatient mental health therapy?
Yeah, that's a really challenging thing. So there's definitely evidence that cognitive behavioral therapy is helpful, although it's not necessarily proven that it's better than other therapies, with the exception of maybe Freudian therapies. There's definitely evidence that therapeutic interventions, which are usually cognitive behavioral, are very helpful for people who are tapering benzodiazepines, which is not exactly what we're doing, but it's pretty comparable to what we're doing. I think the challenge for us is that relationship of mental health treatment to recovery treatment. And I think this is a real problem for us because the mental health treatment is often very appealing to the patient and seems less threatening. Whether it's really less threatening, I don't know, but it's certainly patients perceive it that way. Whereas their recovery treatment often feels very threatening and people go to great lengths to avoid it. So if I have a guy who, for example, is on 4 milligrams of clonazepam a day prescribed by his psychiatrist and is also using 3 grams of heroin a day, I really want to emphasize him going to rehab. That's where I want that guy to go. Would cognitive behavioral therapy help him? I believe that it would.
Later.
Maybe later, yeah. But I think if we get on that now, he's going to be really determined that that is a reason not to go to rehab. So I think that's really the dilemma. For the patients we see who, and we get a few, but really just a few, who are here primarily for prescribed medication and for no other reason, who don't have that subjective experience of loss of control of addictive disorder, I think that would be an excellent strategy. But that's very rare, and I typically, honestly, try to avoid admitting those patients. We get calls, Steve gets calls about every month or so from somebody who's on 1 or 2 milligrams of Xanax or Ativan, who's trying to taper it down, having a hard time. They follow their doctor's orders, they're compliant with their recommendations, but they just feel bad when they stop it, and they just want to cut to the chase and jump into our place. And I usually try to avoid admitting those patients, because I think they have alternative outpatient strategies that would be much more effective. Yeah.
Okay, so we admitted a patient who's opiate and benzos,
Yeah.
has chronic pain.
Yeah.
Okay, so in the realm of chronic pain, there's a difference between hurt and harm.
Right.
But the patient doesn't understand that.
Right.
And when they are, when not only are they being tapered off their opiates, but we're taking their benzos away from
Right.
them, then that creates a big dilemma.
Yeah.
So how do you treat them?
Well, I think that's exactly the sort of medical type patient. For patients who are on chronic opiates for chronic pain, as you guys know, I'm super enthusiastic about changing their opiates to buprenorphine, because as an agonist-antagonist, it lowers their withdrawal and addresses that problem of opiate-induced hyperalgesia. So I think those patients will be a lot better. That's a patient who, if their clinician really wants them on benzodiazepines, I would be comfortable with that. I wouldn't recommend it necessarily. I'd probably try to talk them out of it. I'd probably try to talk both of them out of it. But if their prescribing clinician wants to continue it, I'd be okay with that. I think that difference between hurt and harm is exactly the dilemma we're facing. I think that coming off benzodiazepines hurts.
Yeah.
It hurts a lot, but it actually makes you better, right? And again, it's hard for patients to accept that. So, but I would try my darndest to talk them into it.
Do you think coming off benzos is more hurtful than coming off opiates?
I think that the patients that I see, the subjective experience of opiate withdrawal bothers people more than anything else. So for the most part, patients really, 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 really hate opiate withdrawal. And patients who've experienced opiate withdrawal don't want to have opiate withdrawal. I think that's true of patients with an addictive disorder. I think it's equally true of patients taking pain medication, even if they're following doctor's order. Opiate withdrawal must feel really, really bad. Benzo withdrawal is also really, really bad. Medically speaking, it's more dangerous. People don't seem to remember it with quite the amount of fear and loathing as they do their opiate withdrawal. But obviously in each person it's going to be different. But I think the opiate withdrawal is what people hate the most.
Yeah, I always think about what they say, oh, I'm gonna feel this, I'm gonna feel that, and and it's very hard to tell them, no, it's gonna be okay,
Yeah.
but I mean, they have that
Fear is
terrible
really
fear.
intense. Yeah,
Yeah.
the fear is really intense. Okay, any other questions?
Is that because we have more people coming off of opiates that have done it over and over again? Like somebody else already pointed out, I think it was Steve, that we don't see that many people coming back and back and back to withdraw from benzos. They're usually prescribed it, so that that's not something that they relapse on and then come back.
No, that's not what Steve was. Steve is pointing out the fact that he gets a lot of calls from patients who've never stopped before, who are
Yeah.
stopping
Right.
the first time.
That's what I mean.
Yeah.
Well, they may be getting benzos. I mean, they may go home,
Yeah.
we take them off and they start again.
Right.
Okay.
I think that happens.
Is that it? I think we're done. Thank you so much for coming.
Thank
Take
you.
care.
Yeah.